Hello, my name is Camila,
Ashley.
I'm Stacy.
and this is our 30-minute putting it all together case study for OB. We'll start with reading the case study. So this one is focused on a maternity patient with complex social history, chronic hypertension, and no prenatal care. We are nurses practicing in an urban hospital setting. A 24-year-old Gravida 1 Para Zero woman named Maria presents to the hospital we're working at. She is 34 weeks gestation and having intermittent pelvic pain, which she believes are contractions. Maria is accompanied by her 39-year-old boyfriend. Social history. Maria lives in a mobile home park with her partner and his 7-year-old daughter. She states that she was strongly considering giving up the baby for adoption because of financial and other reasons. She reports she has not had any prenatal care, but has been taking care of herself. She states that she has quit smoking and drinking and is eating daily. She is not currently working as she recently lost her retail job and states that sometimes learning new things is really hard and things have been very stressful. So she relies on her partner for support. She states she is not close to her family as there is a history of significant physical and emotional abuse with her mom and stepdad. Physical presentation and history. Maria is exhibiting significant abdominal pain, and upon further assessment, she reveals that her pain extends to her left flank. Maria also feels warm to the touch and indicates she has had difficulty voiding recently and does not have a history of recurrent UTIs, but reports they typically do not feel like this. As we are assessing Maria, we see that she's very pale, has notable bruising on her arms, back, and legs. Maria is quiet and does not offer information unless asked directly. Her significant other has stayed right next to her since being admitted. Maria's initial vital signs reveal a blood pressure of 188 over 101. She reports that she has had high blood pressure for a few years and was taking lisinopril when she found out she was pregnant, but stopped taking it because her partner said it was not safe for the baby. She reports also stopping her antidepressant at the same time. She reports no other underlying health conditions. An ultrasound is ordered for Maria, which confirms a gestation of about 34 weeks, reveals low amniotic fluid and a closed and long cervix. Maria's labs reveal her liver functions to be within normal range. Her urine analysis reveals no proteinuria, but it is possible for both white blood cell counts and red blood cells. It is positive for both white blood cells and red blood cells. A culture and sensitivity has been sent. Okay, that's a lot. Um,
Yeah.
Let's see. The first question is, what are some specific screenings that may be employed for Maria? Some screenings we could do are an STI screening for HIV, syphilis, gonorrhea, chlamydia, hepatitis B and C, a screening for group B streptococcus, an intimate partner violence screening, depression screening, and also screening for social determinants of health.
yeah. Honestly, to add to that, I'm thinking also like a nutritional
Mhm.
assessment, maybe like iron, vitamin D levels.
Mm-hmm.
I'm a little concerned about her food intake.
Mm-hmm.
Maybe a glucose tolerance test to rule out like gestational diabetes.
Mm-hmm.
Yeah.
Um, but also thinking of the intimate partner violence screening, this case study does mention that he was next to her the whole time. She has
Yeah.
some bruising on her body. Her face is pale. It seems like she's not talking much too. How do you guys think we would go about that? Like,
Yeah, I was thinking that too. Ideally, we would have her in a private environment away from the boyfriend. I know that's not always possible.
mm,
Yeah, I
So,
was thinking if she had to give a urine sample
mm,
oh,
or
smart.
sometime when she was had to be in a private place.
Yeah. Or I know a lot of times, something that's used is there's a couple questions that we just have to ask that we have to ask everyone. If you could just step out of the room for just a minute, um, and then see maybe if he will be open to that. I doubt it if there is some domestic violence going on, but I mean, it's something we could still try.
Yeah. Yeah, also, possibly even taking her to a room and saying that it's for imaging and there's radiation, so it's only one person at a time. Um, if we have true suspicion that our patient is being abused, I feel like it's appropriate to falsify a situation to try to get them by themselves. If
Definitely.
we see
For
that,
Yeah.
her own safety,
yeah,
yeah, for
yeah,
sure. And the baby, yeah.
yeah,
And
yeah.
I know that unfortunately domestic violence is higher a lot of the times when there is a pregnancy involved.
Yeah.
So
Yeah.
yeah, definitely making that a priority.
Mhm.
Yeah. The references for this question are Umana et al. 2024, CDC 2024, American College of Obstetricians and Gynecologists 2022, Committee on Healthcare for Underserved Women 2022, and Ogurick and Hankey 2018. Question number 2 is what patient problems are immediately identifiable in this situation? The first one is severe hypertension. The second one is possible urinary tract infection or pyelonephritis. The third, risk for preterm labor. She also has oligohydramnios or low amniotic fluid.
Mhm.
She has possible intimate partner violence. She has a history of depression, which she's stopped her medication for. She has a lack of prenatal care, and then she also has psychosocial instability and financial strain.
Mhm.
Mm-hmm.
Yeah, I can't help but think about how he told her to stop taking her medication. I
Yeah,
don't know how you guys feel about that, but I don't feel too good about that. Like,
no,
you know, um,
Mm-mm.
I understand like if you're concerned about a baby, but I feel like usually people would go to a healthcare professional to ask if they can continue because she's taking it for her chronic conditions,
Mm-hmm.
mental and physical, and
Uh-huh.
just saying, "Oh, it doesn't matter, stop taking them." Um, you're hurting my baby. Like,
And the rebound hypertension with her pregnancy is
yeah.
extremely concerning.
Mm-hmm.
yeah, it definitely supports the potential um, intimate partner abuse.
Mm-hmm. Yeah.
Yeah.
Um,
Okay.
Also, um, I don't know if this is necessarily actually for this question specifically, but um, her stating that she quit smoking and drinking, but if that's accurate, I guess we don't really know if that's what's actually happening, which could also um, worsen her symptoms if she stops taking her medication and then maybe she still is drinking, which is going to be a depressant as well. So then, yeah, I don't know. Maybe something to have. I feel like maybe that actually could have been something that we could add to the screenings, like a drug and alcohol screening.
Yeah.
Hmm. For
Yeah.
sure.
Definitely like a possibility for substance use relapse.
Hmm.
Even if she
Yeah.
did stop, if she's, stressed out, who,
Hmm.
with her psychosocial stresses. Um,
Want to go on to question 3?
Hmm.
That is, how would you prioritize addressing these
Oh,
problems?
perfect.
I would think priority number 1 would be the hypertension.
Hmm.
yeah,
Definitely.
I agree.
Yeah. And then I would think number 2 would be the possibility of a urinary tract infection.
Hmm. Yeah,
Um,
especially since she has history of them.
yeah. And she's got what appears to be a fever and white blood cells
Mhm.
and red blood cells in her urine.
Mhm.
And then she's got the low amniotic fluid, so I'm worried about fetal well-being
Mm-hmm.
along with that.
Which
And
is increased cord compression risk.
yeah,
Yeah.
yes. And then she's got risks for preterm labor
Mm-hmm.
and um, and then moving on to the psychosocial stuff like the intimate partner violence, the depression relapse risk, and the lack of prenatal care and the social determinants of health, like the financial strain and possible housing um, stuff going on.
Mm-hmm. Yeah, so pretty much sounds like prioritizing her acute issues, and then once those are stabilized, moving to mental health, prenatal, and then social support for the long-term stability portion.
Yeah.
Yeah. Um, yeah.
Cool.
All
Nice.
right.
Um,
Question 4.
sorry.
Go ahead.
I wanted to add, I know one of you mentioned like STI testing.
Mhm.
Maybe that could be added to one of the lower um
Oh, yeah.
um maybe priority
Priorities.
7. Yeah,
Mhm.
lower priorities, just like as a, precaution, because it could harm baby too.
Oh, yeah, for sure.
But
Especially with the preterm labor risk and
Right.
yeah. Yeah, that's a good point.
okay. Mhm.
How might these problems impact the duration of the pregnancy? Um, Pretty much all of these can end up in preterm delivery.
Mm-hmm.
Hypertension, UTI or pyelonephritis, oligohydramnios, and actually intimate partner violence as well. They
Mm-hmm.
all can result in preterm delivery.
Mhm. Yeah.
Yeah. Um, let's see. Hmm.
Um,
Oh yeah, and then I know also low birth weight was mentioned because the
Mhm.
like from due to IPV and psychosocial stress can impair fetal growth, which could lead to low birth weight, which then I feel like would be another problem on its own because the baby will probably be in the NICU if they are preterm, and then I don't know the ability of the mom and the boyfriend to care for the Ni or the baby well in the NICU. So I would think that that would be another potential obstacle. Um,
um,
mo literally segue into the next question.
yeah. Also,
Um,
like, in treated
Go
mental
ahead.
health, you know,
What'd you say?
also in treated mental health, she
Mm.
went from taking her mental health medication to completely cold turkey off of it, which first is not recommended ever.
Mm-hmm.
Second, now she's just dealing with these, you know, emotions. And not only does she have to deal with it, but she's also gonna have to try to take care of herself while she's pregnant. It's
Mm-hmm.
definitely gonna affect your prenatal care adherence,
Mm-hmm.
which is gonna shorten your gestational length. Like you're gonna have an earlier birth.
And then there's the risk of PPD or
Yes.
And
uh,
I'm wondering also about increasing your suicide risk.
yeah,
Yeah.
definitely. You would think
Yeah. I would even add that to one of our priorities to
screenings.
ask her. Yeah.
Mm-hmm.
Like, do you feel safe or do you feel like harming yourself?
Yeah, I guess that could probably correlate with IPV, but it is separate considering it's more directed to herself or
Yeah.
her baby, if she's thought about harming her baby.
Yeah.
Um,
The references for question 4 are ACOG 2022B, ACOG 2023, Keelman and Shanks 2021, Guo et al. 2023. And question 5 is what are some potential concerns for fetal impact? Hypertensive disorders impair placental blood flow, which significantly increases the risk of IUGR, preterm birth, and stillbirth. Low amniotic fluid, especially in the third trimester, increases the risk for umbilical cord compression and fetal oxygen compromise, which can lead to hypoxia and fetal demise. And pyelonephritis or UTIs during pregnancy elevates the risk for preterm labor and delivery, even when treated.
Oh, wow. Hmm.
And intimate partner violence during pregnancy is linked to an elevated risk of preterm birth, low birth rate, and also poor prenatal care, all of which adversely affect fetal health.
mm, hmm
Something I would add to that is like lack of prenatal vitamins
hmm
also cause neural tube defects,
Mm-hmm.
hmm
considering her past of substance abuse and
hmm
nutrition. It's something to keep in mind
Yeah. I'm
because
sure she has
yeah,
many deficiencies.
yeah. Also, just having a lack in prenatal care, she probably doesn't even know.
No, yeah. Let's see.
Our references for number 5 are Mayo Clinic 2018, uh, oleohydramnios treatment for mothers, ND, Berry et al. 2023, Steele Baser 2024.
Okay, let's see. So continuing to what further assessment is necessary. So based off of her blood pressure and hypertension history, repeat of BP measurements, and check for symptoms of preeclampsia. We know that's a big risk for her specific case. Urinalysis and urine culture to confirm infection, which it sounds like from um, previous urine analysis there is white blood cells and red blood cells. Um, and then fetal monitoring. So, in relation to the impact on the fetus, we want to ensure that we're monitoring non-stress test and biophysical profile to evaluate fetal heart rate, movement, and then due to the low amniotic fluid, monitoring for risk of cord compression, things like that. Abdominal and pelvic exam to assess for preterm labor signs. Um, let's see.
I'd like to add to that.
Yeah.
Also a drug screen because
Mm-hmm.
and a history of drug use. Um, Assessment of home safety, like the environment where they live, like is there lead in their paint or something like that, you know? Some questions like that. Or H&H too, checking her hemoglobin.
Mm-hmm.
Um,
Yeah.
See if she's anemic.
Okay. References for that. American College of Obstetricians and Gynecologists 2022, Committee on Healthcare for Underserved Women 2022, and Humana et al. 2024. Um, So, considering what we've discussed thus far, two care planning goals that might be considered for Maria. Maria's blood pressure will remain less than or equal to 140 over 90 throughout hospitalization with no signs or symptoms of preeclampsia by the time of discharge. Um, Fetal monitoring, NST/BPP, Will show reactive tracings and amniotic fluid index within normal range during hospitalization with no persistent decelerations or non-reassuring findings. So let's see. I think to add to that, setting those two goals, just making sure we are educating Maria. So making it more of an interactive experience, teaching her warning signs, using Teach Back, and then like if we need to give her any additional educational materials, I'm sure that because of her lack of the ability to have prenatal care, she might not even understand like what preeclampsia is or the risk for it or low amniotic fluid. So just providing education regarding that so that she's aware of these of what the personal goals we're setting for her entail. Um, and then for
Well,
the IPV, I was also thinking regarding, I know we discussed her boyfriend being with her, so I guess it depends if we're able to get her alone, but providing her education regarding that so that she has resources or materials or education on where she can go or who she can call if she decides not to disclose information to us specifically.
Yeah.
yeah, I think then the next question covers what topics might require immediate
Oh,
education
yeah.
for Maria.
So resources for 7 were Bronthal 2025 and Humana et al. 2024. Um, Topics may require immediate education, severe hypertension in pregnancy, so risk, symptoms, importance of medication adherence, warning signs of preterm labor, fetal movement monitoring, safety and resources for possible intimate partner violence, and then mental health awareness. So, yeah. Um, Sources are Bromfield 2025, Mayo Clinic 2022, Humana et al. 2024, Committee on Healthcare for Underserved Women 2022, and ACOG 2025. Who are important professional interdisciplinary team members to coordinate with on care planning for Maria? So obstetrician for maternal fetal medicine specialist, and then social worker, case manager, mental health professional, IPV advocate, and then dietitian slash nutritionist.
Also, I don't know if this would go under number 9, but referring them to the WIC office,
Mm-hmm.
great
Mhm.
option too. Even
Yeah.
during pregnancy and postpartum, she would get lots of support. There's also another program called Maternity Support Services. They can also help. They have like a social worker and a nurse that helps like cover any gaps in healthcare.
Mm-hmm.
Yeah, I was also thinking of a nurse visiting program
Mm-hmm.
where they get nurse visits at home.
Yeah.
Yeah.
That's been shown to have really positive outcomes.
Mm-hmm. Yeah. Great points. Um, what potential social determinants of health or environmental factors are identifiable in this case study? So, economic instability, housing stability concerns, food insecurity, limited access to healthcare, interpersonal safety concerns, low social support, and educational barriers.
Maybe even transportation barriers to
Mm-hmm.
um, maybe digital access use, like if she doesn't have a stable internet connection to be able to
Yeah,
schedule appointments or
for
reach.
sure. I feel like that also keeps her more, oh, what's the word?
Isolated.
Yes,
Yeah.
exactly. Yeah.
Mm-hmm.
Yeah, also high stress and mental health history. Just the
Hmm.
fact that she has a history of depression and a recent discontinuation of her medication.
Yeah.
Um,
Yeah.
well, Looking at number 11, given Maria's environment and medical history, what are some possible contributors to her current present presentation? Starting with uncontrolled hypertension, she stopped her medication. Lack of prenatal care, possible untreated infection, psychosocial stress and limited support. Her stress hormones are worsening, hypertension, job loss, financial dependence, low social support, kind of circling back to that isolation. She's being isolated. Food insecurity, suboptimal nutrition. She probably is deficient. Mental health history, environmental stressors, unstable housing, unsafe home environment, which equals to chronic stress, which also limits ability to prioritize health needs. And also the partner having an input on her medication decision,
Yeah.
you know, so it's unsafe to discontinue those medications suddenly.
Yeah, I feel like that's tough because if she's unwilling or unable to remove herself from that situation, I feel like it makes it difficult to know what resources we can provide, without making it more unsafe for her because we don't know how he's gonna react. Uh, so
Yeah.
yeah, I don't know, it's hard.
Also, being pregnant alone um brings down your immunity. Like you're
Hmm.
more easily susceptible to getting sick. But then on top of that, you put all this stress and control into her picture, and that's just making her immunity even worse.
Definitely.
And probably making her blood pressure even worse too, being stressed out.
Yeah,
Mm, yeah.
chronic stress.
And then your blood pressure is already elevated anyways when you're pregnant. So then it's like,
Yeah.
yeah, it's just a cycle.
Mhm. Um, what are some evidence-based physical interventions that can be used to develop a plan of care for Maria? So, blood pressure stabilization, management of suspected UTI slash pyelonephritis, fetal surveillance, like a non-stress test or a biophysical profile, um, IV fluids, possibly,
Mhm.
or
Antibiotics.
yeah, for the amniotic fluid volume. I know it's dangerous to do it, but if it was really bad and, indicated by the doctor, if she got adequate prenatal care,
Hmm.
to help build up that fluid back. Um, and also pregnancy safe, antihypertensive therapy,
Hmm.
she should still be taking her blood pressure medication. I'm pretty sure they get like baby aspirin during pregnancy. Um, but yeah. Um,
Possibly continue, talk about continuing or restarting her antidepressants,
Hmm.
if that's even possible with her partner
yeah.
around.
Yeah.
The references are Birth Bronthal 2025, Habak and Griggs 2024, American College of Obstetricians and Gynecologists. What are some evidence-based psychosocial interventions that can be used to develop a plan of care for Maria? So we want safety planning for intimate partner violence. These interventions reduce the risk of future victimization among marginalized intimate partner violence survivors. Also, home visiting case management, like a nurse family partnership, offering home visits by the RN to first-time low income mothers, connection to material support services such as WIC, food banks, housing assistance programs, and transportation vouchers. Um, yeah, maybe like prenatal education classes,
Mm.
culturally sensitive, like um, approach to address if she has any mistrust in healthcare, if that's the reason why she's not getting prenatal care.
That's a good point.
Yeah. But our references are Sabri et al. 2021, Nurse Family Partnership, Chang Gent 2025, Merchant et al. 2023, D. Tosto et al. 2021. What are some family-centered interventions that can be employed in this case? Home visiting programs strengthen family engagement and birth outcomes. Also, family inclusive nursing care during transition to parenthood aids maternal adjustment and confidence.
Mm-hmm.
Uh,
Yeah. Home visiting programs like we mentioned earlier, that's a good one. Um, family inclusive nursing care during transition to parenthood.
Encouraging bonding activities.
Hmm.
Also, if it's safe, like involving the partner in education,
Yeah.
on recognizing like maternal and fetal distress signs, maybe,
Hmm.
um,
Yeah, and then another thing, follow-up plans, and being concrete with them. So like specific appointment dates, home blood pressure monitoring, clear triggers for seeking care, like things to avoid, just to like have in her chart so that we know when we're contacting, um, what she's more likely to be receptive to and not receptive to, regarding her home life.
yeah. Our references are Research Brief, Screening as a Tool for Family Engagement and Early Home Visiting, 2023, Cesar Santos et al., 2024. What are two ways you can measure outcomes for Maria? Well, we can check her blood pressure, maternal blood pressure stabilization, track and document her Maria's blood pressure readings during hospitalization and follow-up visits with the goal of maintaining less than or equal to 140/90 consistently. Also, fetal well-being maintenance, measure the monitor the results from a non-stress test and biophysical profiles. Goal is reactive NSTs and BPP scores above or equal to 8 out of 10 through the remainder of pregnancy. And our references for that are Bronthal 2025 and Umana et al. 2024.
Great.
But yeah, that was our putting it all together case study, OB. Um, yeah, we hope you enjoyed watching this.